Welcome to Fluorescene.
Hello, I'm Glazier, and I'm the host of the show. Thank you for joining us on our 16th episode. Don't forget to subscribe to our channel by hitting that red button below for updates on shows and segments and more. I hope your weekend was good. It was a very special week for me, the week after the first live conference in a full year. Yes, I know, exciting. SECO was last week. I got back and all I can say is, wow. These conferences are energizing in normal times. This one was super energizing because of the situation. I'm so glad that our industry is still here, right? Something inside me, some unconscious thought questioned if there ever would be still even be an industry after this whole thing. I know it's ridiculous, but I promise the house is safe. It was meaningful that the pandemic started with SECO being the last large live conference and brought in the world after. I hope your weekend was good like mine. This week in ODs on Facebook, there was a post about those patients who the second you walk in the exam lane, before you can even say hello, ask, has my vision changed? Because all optometrists are psychics. Didn't you know that? And as if it couldn't get more ridiculous, there are brand new patients we've never seen before who don't bring their glasses or written RX from their last doc, and the first thing they want to know is the same thing. Has my prescription changed? Then we've all had the kind of patients who don't want to answer any questions at all, like we're supposed to conjure their diagnosis based on their chief complaint alone, like the patient who knew he had a wood chip in his eye and didn't say anything until the doctor mentioned it, finally admitting, I know it's there, doc, I just wanted to see if you could find it. Don't you love that? Or they say, nah, doc, I'm going to make you work for it. Or, I want to see how good you are. Another one of my favorites. Love those ones. You might want to tell these patients, I don't do exams on patients who don't answer questions, so you're going to have to answer these questions and way more, because which is better, one or two questions are coming up, and if you can't answer those, been great knowing you. That's the way out to check out. Copays are not refundable, and we will be billing this. A doc recommended watching the movie Zero Dark 30. That interrogation methods he picked up from that show might help you. Or you can always respond, we'll get along great and we'll be done in record time because it just so happens that I don't answer any questions after the exam. Eye exams. They're so much harder when patients plead the fifth, right? A doc posted this visual field and asked if anyone recognized this puzzling field defect. The overwhelming majority figured it out right away. It's a poorly placed lens holder in a visual field machine. A few suggested great names for this frequent condition, like lens holder retinopathy, or trial lens holderitis, and lens holder scotomata. One doc said, it's a boy. Another likened it to Rocky after he runs up the art museum steps. Whatever the name, I'd like to see an ICD-9 code so I can bill every time I have to rerun one because a patient didn't listen to instructions. Now, a doc posts this chief complaint and challenges the community to see if anyone has ever had the same. Yikes. One doc said, can't picture a lawsuit in this case. He doesn't have a leg to stand on. And looks like the message got cut off. Personally, I'm stumped on how it's related to his eye. Get it? Stumped? Is that wrong? Well, I'll go out on a limb and bet that is this related to his leg. Whoever did the amputation will have to foot the bill. Also, need to explain to the tech that the time it takes to repeat these fields costs to practice an arm and a leg, as you can see. Sometimes you got to put your foot down. Oops. Maybe not this time. There's a joke about IHOP pancakes in here somewhere. I just couldn't come up with it. A patient posted this pic to point out that sign placement is very important. I knew there would be a few free rectal exam comments. Hope there's no lunch rush. So many jokes, so little time, so I wouldn't want to judge. Anyhow, the doc is probably just trying to increase their bottom line. Well, ass cleaning aside, we've got a great show for you today. Guests include Dr. Barry Eiden, President and Medical Director of North Suburban Vision Consultants in Deerfield, Illinois, founder of the International Keratoconus Academy of Eye Care Professionals, and investigator on several large-scale medical trials. And Dr. Jackie Thies of the Concussion Care Center of Richmond, Virginia, a thought leader in neuro-optometry and binocular vision. Dr. Judy Hu is here with another episode of Who's Got Glaucoma, and Dr. Solomon Gould with a new segment, FYEye with Dr. Gould. Dr. Gould runs through practice key performance indicators that private and corporate practice owners, as well as those who hope to own or become a leaseholder, need to be aware of. And there's much more, so subscribe by hitting that red button below. Sit back, pour yourself something, preferably not Fluorescene, on your patient's white blouse, and enjoy tonight's show.
Dr. Barry Eiden is an honors graduate of SUNY Optometry. He completed a residency in ocular disease at the Westside VA in Chicago. He is president and medical director of North Suburban Vision Consultants. He's served as an assistant clinical professor and chief of primary eye care services at SUNY Optometry. Barry is a fellow of the American Academy of Optometry and past chair of the contact lens and cornea section of the AOA. He's president and medical director of Keratoconus Specialists of Illinois and president and founder of the International Keratoconus Academy of Eye Care Professionals. As a research consultant for contact lens manufacturers, Dr. Eiden is considered both an authority and an innovator in the area of contacts. He is co-founder and president of iViz, the Eye and Vision Research Institute. Dr. Eiden was an investigator on the CLEC, Collaborative Longitudinal Evaluation of Keratoconus Study, as well as many other clinical investigations and studies in the eye care field. In 2019, he was awarded the American Academy of Optometry's prestigious Founders Award. He is a well-known lecturer both nationally and internationally, has done interviews with television stations and networks, major newspaper and magazines, and has been published in many scientific journals. He also serves as associate editor, cornea and anterior segment for odiesonfacebook.com, and is, in my opinion, all-around great guy. So welcome, Barry.
Thank you, Alan. It's great to be here. After listening to that introduction, it sounds like I should be ready to retire. It's enough.
I know, doesn't it? Did you put the check in the mail?
Absolutely. I'll give you an extra actually coming in too, a little bit of a tip.
So happy to have you here today, Barry. I wanted to have one of the leading keratoconus experts on the show. I want to start today with some things that I learned about you. So one interview I read said you chose optometry because of an eye exam you had and you thought it was cool. But the real reason we all know is because your last name being Eiden, like Eiden.
There's no doubt that both of those are actually true. Coming from a dad who worked in the garment district in New York all his life and ended up developing a company in the garment district, Dad said to me very early on in my life, there's no way you're going into this business. He didn't give me a summer job. He wouldn't let me come in. He just said, this is not for you. You've got to be what? A doctor, right? So when I was thinking about where to direct myself in the medical field in undergraduate, I visited an optometrist and I went into his office, and what was the first thing I saw? All the instruments. This guy was very tech savvy back then. And I said, this is cool. This stuff I like. And he invited me to come to, he had study groups with a few local ODs, and I went to some of those study groups, and I really enjoyed kind of the philosophy of optometry. That's where I learned about it. But until I went to optometry school, I had 20/20 acuity, and my parents never took me for an eye exam. So it wasn't until optometry school that I actually had my first eye exam.
It reminds me of a joke of an immigrant family in which you're expected to pick whatever career you want as long as it's a doctor, lawyer, or engineer. If, for instance, you want to be a musician, then your parents would say, great, just make sure you're a doctor, a lawyer, or an engineer.
Exactly. You can sing all you want. And what was funny, getting back to Dad, was the reason why I even learned about optometry was where his factory was in Manhattan. He went to lunch with an optometrist every day who had an office near his factory. Of course, he called him Doc. He would go to lunch with Doc every day. And he says, that is a good profession. It's a nice, clean profession, he said. So he encouraged me. The name, interestingly enough, Eiden, Eiden, obviously not that bright. I never put two and two together. But when we got our first car, my wife said, you have to get a vanity plate. And it's obviously what it's going to be. It's going to be EYEDEN. And since we had two cars, she said, since I came up with it, I'm Eiden 1 and you're Eiden 2. And that's how it's been ever since.
Awesome. That's awesome. Now, you talk about your dad, and he's quite an entrepreneur, and you are too. And so I guess entrepreneurship runs in your blood. You have two practices, a research company, you consult and lecture, you do it all. You've really merged your talent for entrepreneurship with your profession. What advice would you give to young ODs with similar aspirations?
Wow, that is a really great question. And I'm asked this all the time. In fact, last night, I was just on a call with one of my former interns who was making a business decision about going into a startup practice. And so you're absolutely right. I think about this all the time. I think with each passing generation, the challenges are different and greater. I remember my professors teaching me practice management, talking about how they opened cold and they sat in their office for the first year or two reading the paper and drinking coffee. And I was saying to myself, I can't afford to do that. I have school loans. They never had school loans. Now the loans are much, much greater. I think it takes that much more background research and doing due diligence to figure out what is the best path. For me, I was very lucky. When I went into private practice, with a gentleman who was very altruistic. In fact, he brought me into the practice. He was retiring in a little under 2 years. It was all the plan for me to take over. And the first year when nobody wanted to see me because I was an unknown quantity, basically he knew that my background in ocular disease was very strong and his wasn't. He was not from that generation of optometry. So what he did at the beginning until patients would see me is that he would do the introduction, he would refract the patient, and when it came time for eye health assessment, he said, I'm going to bring in my associate. And I would come in and I'll do slit lamp and I dilate them and pressures and fundus exam and so on and so forth. I got to meet almost every patient in the practice. So when he retired, it was a very smooth transition. Obviously, looking back, that was a major financial commitment he made in me. He was paying me a salary. And in essence, for the first almost year, I didn't generate very much of anything. That's unbelievable and maybe not that common these days. But boy, if a young person could ever get a situation like that, that'd be fabulous. Well, I hope that more of the senior ODs out there are realizing that. Maybe we have to get that message across in today's day and age, especially this year with COVID hitting practices pretty darn hard. Making that kind of financial decision maybe is even harder than it was before. But you're right. In the long term, it is to the advantage. It increases the value of the practice. So maybe, the doctor might be taking a little hit at the beginning, but the value of the sale of the practice is greater when the new doctor is integrated better.
Two practice owners in our age range could talk practice management all day long. But you're the cornea guy, so if you don't mind, let's move over to talking cornea. I have a lot of questions because I haven't really kept up with corneal cross-linking, but there's standard epi-off and accelerated now, and a study in 2018 showed that epi-off is better at reducing maximum keratometry than accelerated, but accelerated doesn't reduce central corneal thickness and endothelial cell density as much. Now, 3 years later, is there any information on which method might be more preferential?
Mm-hmm. So I think we should start off by saying right now, today, there's only one FDA-approved method for corneal cross-linking. That is it was former Avedro, now Glaucos, iLink is the term that's now being used. It's an epi-off procedure in the standard Dresden protocol, the original method that was developed out of the group out of Dresden, Germany. Epi-off, applying the UV light of the specific wavelength for a specific period of time. That is the only FDA-approved method. And as such, it is also the only approved method that is being reimbursed under medical health insurance. And many, many more insurance companies, by the way, are covering it. Obviously, cost becomes a factor for a lot of these people. However, of course, technology keeps moving forward. So other methods of cross-linking that you mentioned, accelerated cross-linking, even more importantly, epi-on cross-linking, have gone through a variety of clinical studies. And in fact, Glaukos has their epi-on method that they've already accumulated their data. And I believe that the study is closed, but they're analyzing the data. So I'm encouraged that we will see changes in cross-linking to make it more effective, but even more importantly, safer for the patient and more acceptable. We all remember from the early days of refractive surgery, and Ellen, as well as anybody, the first days of PRK, well, it wasn't the most pleasant for patients, right? You would talk about doing this procedure to rid them of corrective eyewear, and they would come in the next day miserably uncomfortable, slow recuperation of vision, ultimately doing well in the vast majority of cases. Then LASIK was developed. And I remember being in, because I was running a couple of refractive surgery centers a number of years ago, and being in the clinic and doing the one-day post-ops, and we were doing both PRK and LASIK, and you'd see the PRK patients come in sitting there like this, and the LASIK patients there like this. There is an analogy between epi on and epi off in that regard. We get, it's less painful, it's quicker recuperation of vision. I think ultimately it's going to result, if the studies come out the way we think they will, in a equally effective method that's just way more patient friendly. So we're going to see lots of things like that. And then there's the use of cross-linking for other things, even targeted cross-linking to induce changes in corneal shape and curvature. So everybody should realize that when you're suggesting corneal cross-linking for a keratoconus patient, it is to stop progression of disease. They'll always talk about, oh, well, you get flattening of the cornea, maybe reduction in severity of disease, but it's not as, the current method isn't very, very predictable. So we never promise patients that. What we're telling them in a high level of confidence, in the upper 90s%, that the progression of the disease will halt from cross-linking. That is the purpose of cross-linking.
Yeah, they were investigating it for a lot of things. There was an investigation on enhancing stabilizing LASIK results if someone continues myopic creep after LASIK. What does the name Damian Gatnell and the phrase no rub, no cone mean to you?
So I would say to you that that's the whole discussion of eye rubbing and keratoconus, and which came first, the chicken or the egg. So there are those out there that think that eye rubbing causes keratoconus, and there's a whole nother, maybe even a larger group that feels that eye rubbing exacerbates keratoconus. I'm in that second group. I think keratoconus is a disease that's determined by your genetics, but environment can induce progression and increase severity. So I think the term epigenetics may apply to this, where, yes, we have a genetic predisposition that can be influenced by environmental factors. Kind of like myopia, right?
Yeah, similar. Nothing happens without genetics playing a role. If you're prone and you exacerbate it, of course, it makes total sense.
Exactly. That's the camp that I'm in.
Now, let's talk about your baby, the International Keratoconus Academy. The mission I read on the website was it's an organization established to promote ongoing professional education and scientific development in the area of keratoconus and other forms of corneal ectasia. Now, I see you have some real power players that you brought together in this organization. Start by telling our viewers a short overview of the organization and specifically about the seminal research that you're doing on pediatric prevalence, where I think you have something crazy like 3,000 school-age subjects.
So let me start by saying that the organization was founded about 6 years ago. A group of us were just sitting around and we talked keratoconus because we're nerds about that. And we realized, and everybody's sharing the concept, that there's so much misinformation out there. And when we see patients in clinic, and I know you have seen them many, many times in your career, they come into the office and you just shake your head about mismanagement. So in some practices, patients will go in with keratoconus and they're like pushed right into corneal transplants. You'll go into other practices and they'll be fitting contact lenses until their corneas are scarred down to the nth degree. And so there's this siloing of treatment. And we believe that you have to approach it as a comprehensive management. And that's kind of was the seedling of IKA. And we said, let's see if we can form an organization with all of the eye care groups, whether it's ODs, MDs, and other affiliated eye care specialists and interests, and try to push forward the most current knowledge and research in the field of keratoconus, both early diagnosis and management. So our mantra is to stop the progression of disease before it influences negatively vision. And that's really what it's about. And we were able to get, as you said, a powerhouse of all eye care professionals involved in this. And it's really starting to take off. We have, as you know, our website. We have a social media page, which you're an expert in that field. And the number of members increases virtually every day. We're getting closer and closer to the 1,000 member group. And remember, this is a disease, just one disease. It's not like saying cornea or contact lenses, it's keratoconus. And so our primary goal is education. And we do that in a number of ways. And 2021 is going to be a really big area for education. We're going to start putting on a lot of virtual educational events. We're forming initially a journal club that we may do every month, where we'll have authors from some of the most important research published out there explaining their papers in short but really concise and clinically relevant ways. But then our hope as we get out of this COVID is to go live. And we've done educational events within larger meetings, AOA, the Academy. We've done meetings at the Specialty Lens Symposium and things like that. But ultimately, we want to have our own freestanding meetings and be really able to educate. Then you mentioned our study interests. So we've completed one major study that I think will be a seminal study and may have the potential to really influence what all of us do, especially with kids in our clinical practice. And that's the pediatric prevalence study. So let me tell you quickly a little bit about that. So we were able to get a grant thankfully through Oculus, who provided a Pentacam corneal shine fluke tomographer to be placed into a pediatric clinic here in the city of Chicago that was being run by people from the Illinois College of Optometry. And what happened was there were school-age kids from kindergarten through 12th grade who were bussed in every day to this clinic to have comprehensive eye exams. Most of these kids were underprivileged, vast majority African American and Hispanic. And we could talk a little bit about that with the results. But basically, thousands of kids a year were coming in and having comprehensive eye exams. And so what we did was that we randomly selected individuals as they're going through their eye exam to just routinely run a shine fluke-based tomography using the Pentacam. And we did screen close to 3,000 individuals, over 4,000 eyes. Interestingly enough, utilizing some of the statistics to screen for keratoconus, we were seeing, this is going to be unbelievable, a 1 in 5 red flag. That doesn't mean 1 in 5 had keratoconus, but there was enough to make us suspicious of keratoconus in 1 in 5 of these individuals. Wow. Now, statistically, if you look at a lot of studies out there throughout the world, we used to think keratoconus was 1 in 2,000, but that was based on pre-corneal topography. Forget about corneal tomography. It was based on, retinoscopic and keratometric findings from a screening done in the mid to earlier 1900s. And all of the newer studies are showing a much higher prevalence of keratoconus. We believe it's definitively under 1 in 1,000. We probably believe it's closer to 1 in 5 or 600. And if you think about that, imagine kids coming through your practice, right? And thinking that 1 in 500 could have early keratoconus. And we now have a method to stop it from becoming visually significant in a safe and effective way. Oh my God. I mean, Alan, we talk about this at every one of our lectures. When you see a kid who's 12 or 13 years old in your practice, the routine standard of care is to measure their eye pressure, right? Whether it's Gould tonometry or air puff, whatever you use, whatever technique you use. I always ask our audiences, how many in the audience in their career have diagnosed primary, not due to injury and not due to congenital glaucoma, but how many have diagnosed primary open angle glaucoma in that age group? I know I've practiced for 30 plus years, 0. Yep. But yet I still measure their pressures. And then 1 in 500 of the ones that we see have keratoconus and we're not screening for it.
Makes sense. That's, I think the accessibility of technology has made the diagnosis more prevalent. It was always there, but we just see it more with the technology now. So we know the numbers are much greater.
100% correct. And that's the challenge. And that's kind of the gauntlet that AIKEN is throwing out to industry. And we believe that with the results coming out this year, we're going through statistical analysis right now, really detailed statistical analysis of these pediatric results. But the gauntlet is for industry to develop instrumentation that's accessible and affordable to primary eye care to effectively screen for early keratoconus before it affects vision. We can't depend upon slit lamp findings or distorted keratometry. To a certain degree, we can't even depend upon placido topography because most cases of abnormalities in placido topography, it's already affected the front of the cornea and most likely has affected vision. We know that it all starts on the back of the cornea and with changes in corneal thickness distribution. these are measures that we can't measure with traditional instrumentation. But I believe that industry can develop appropriate instrumentation and make it affordable. That's the gauntlet we throw down. Yeah, so we are really ramping up our educational efforts. One of our executive board members, John Gillies, is really taking the lead on this, and John's going to help us get that organized. We just had a meeting virtually the other night. We're working to put together, first of all, a monthly, as I mentioned, journal club, where we're going to be doing research reviews of published papers, hopefully get some of these authors to come on and do a 20-30 minute review of their research and how it is clinically relevant. And then we'll have some of our IKA board members on to have discussion and take questions. That can go on monthly. That's one thing we're trying to put together. And then we're going to do larger CE events, initially virtually and then live. So we're really trying to ramp up the educational aspects. I want to invite anybody with any interest, which should be most all of us who in keratoconus, to join IKA. It's absolutely free. Our sponsorship from industry allows us to do this for free. So if you go to our website, if you don't mind me saying
Please.
the website, it's www.keratoconusacademy.com, keratoconusacademy.com, and you can go to the subscribe page, and there's a little code for complimentary membership. Boom, boom. When you're a member, you start getting all of our communications through our email list, our listserv, and we share ideas and thoughts, and we tell you when new presentations will be out there. And if you have cases, you want to throw it out to some of the biggest names in optometry and ophthalmology and keratoconus, you could just post a case and people will give you feedback, probably more than you want.
So tell us a little bit about IVIS, Eye and Vision Research Institute, which is your R&D company.
Yeah, really interesting. So back, oh goodness, it's got to be close to 20 years ago. A dear friend of mine who also practices in the Chicago area, Rob Davis, and I, we've been involved in clinical studies in contact lenses, solutions, and pharmaceuticals for years and years. And we realized that there's a lot of small companies out there that want to get research done, but they don't have the the system in place. They don't have people to conduct the research. They don't have study sites. They don't have statistical analysis. And we had connections. So we just decided, let's form a company. So you got Eiden and Davis, IVIS, forming a company where we can do research projects for generally smaller companies. We've done it for some of the larger contact lens companies that don't have the interest or ability at that time to do perhaps a smaller study that internally they don't want to do. So we've been running studies for years and years, and it's just another fun thing to do, to be honest with you.
I think it's a little bit more than fun. It's a business. Any interesting studies you can tell us about that we can look forward to learning about?
The biggest study, I think, impactfully, although there were issues with the study, was our study called the SMART study. You may be familiar, myopia dude. Yep. So you know about the SMART study. So back then, when Ortho-K was just getting approved, right, which was about 2001, there was a group in Chicago. A lot of people have been doing Ortho-K off-label for years. We got involved on the preclinicals for Paragon, so we didn't do it before that. So a group of us got together, and we kind of got together to potentially do cooperative marketing. So we would educate the public about Ortho-K. And we realized soon at this dinner that we got together that none of us could agree on a damn thing about doing cooperative marketing. So that kind of fell through the wayside. But what was agreed upon at that meeting was that for Ortho-K to ever gain traction, the only advantage of it that really would resonate is myopia stabilization. We knew it back then from clinical input, but there were no great studies. There were suggestive studies. There were pilot studies. So at that point, we put together the largest myopia management study of orthokeratology ever done before, where we had over 300 subjects doing a 3-year study, 150 in daytime wear soft lenses and another 150 in overnight Ortho-K. And we monitored them for refractive changes, biomicroscopic abnormalities, if they should occur as adverse events, and axial length elongation. And we showed in that study definitively that the Ortho-K group progressed in myopia refractively at a significantly slower rate than the daytime wear soft lens wearers. The problem was in that study in axial length, and we learned a lot. And the reason was the instrumentation. we were utilizing ultrasonic axial length elongation that was very technologically challenging, and we had 10 study sites, and the data was all over the place. So this AL data did not really support because it wasn't quality data. Today we know we use instrumentation that's much better, as you well know. Utilization of techniques that are reliable with much less noise and much less test dependent or examiner dependent. So that was probably the biggest study that was underwritten with a unrestricted research grant from Bausch and Lomb, which was phenomenal. They said at that point for outside studies, it was the largest study and most expensive study that they'd ever done. And Euclid provided the Ortho-K lenses. And one of the cool things that we learned from that was empirical fitting of Ortho-K works really well, because up to that point, most of us were doing Paragon diagnostic lens fitting. We realized that first lens off of Ks manifest in corneal diameter resulted in the low 80s% of first lens hit. And that was huge. And now they've even refined their algorithm better. And I believe they're in the upper 80s with first lens. And we're seeing that kind of success all the time.
And that's thanks to the reverse geometry lenses. You, like me, I used to fit Ortho-K with spherical lenses, and getting them to balance on the apex of the cone was a lot of hard work. I love how candid you were about the error in that study having to do with using the handheld measuring devices for axial length. That being the reason, just so the viewers know, every time you measure axial length, you or whoever is measuring it comes in at a slightly different angle with a slightly different pressure. And for that and other reasons, ultrasound, if you're really doing myopia control, it's vital to get an instrument that's fixed, like the IOL Master or Oculus's device, because axial length measurement and repeatability in axial length measurement is crucial. So
it's crucial. Well, I lecture on this as you do all the time. We've been in advisory meetings together on this over the years. And, I've always been a proponent of measuring axial length as a critical element of myopia management. I've had arguments with really well-known myopia management people, whether you need to measure axial length. And I always use the analogy of Weight Watchers. It would be like going into Weight Watchers every week and just seeing how loose your pants are, as opposed to getting on the scale. So, I have that slide actually in one of my talks. We got to measure what we care about. We care about axial length. That's what we're worried about, right? All the complications are due to the elongation of the eye. How could you not measure it? Once again, gauntlet to industry. Make it accessible and affordable. It's happening, as you know. You've seen, I think there's a Topcon topographer now that has axial length. Oculus is developing an autorefractor that has axial length called a Myopia Master. Hopefully it'll be approved soon. The Lens Star system, the IOL Master, which is what we use in our practice currently. These technologies are becoming more and more affordable, more and more accessible. And if you're going to take the dive into myopia management, what do you have to do? And Alan, you know this better than anybody. You got to make investments in your technology. We've been dedicated in our practice to technology from day one. Why? Because I thought that was what was cool about optometry. That's why I went
into
it.
So
right? The great toys, big toys for big boys. And, all of my sales reps love me because it's really hard for me to resist new technology.
I'm the same way. More than one machine that's turned into a coat rack for me, just because it was sexy when I first heard about it. So we're going to head to the end of the show and wrap it up soon. And I want to move outside of clinical care and have you tell our viewers about your passions outside of optometry.
Oh, yeah. So if I had to really identify, there's a few things that I love in my life and make life worth living. Of course, number one is family. And I have, I think the greatest family, greatest kids, greatest wife. I have two kids who live out in San Francisco, and with COVID, haven't seen them for over a year, and I'm going out of my mind. And, these virtual conversations are starting to get old to me. Well, thank God, myself, all of our doctors, including my wife, who's also an OD, by the way, we're all double vaccinated. We're ready to rock and roll, and we'll be heading out there very, very soon, and I can't wait. And I just want my kids to get vaccinated so we can give really big hugs to each other. Otherwise, the other things I love playing golf. I'm really into wine, as you well know. Love to drink the wine. You're trying to help me, along with a few other friends like Tom Arnold, in appreciating the brown stuff, the brown liquor. So I've been playing around with a little Macallan 18 over there. I like to play guitar. And in terms of lifestyle, I love to travel, as you do. So I can't wait to get going again in those areas.
We'll definitely get to the bottom of the bottle next time. I found out last week that I developed an allergy to wine. It stuffs me up. I can't sleep, but I don't miss it too much because I don't have a sweet tooth. So I'm okay with that. I use that extra time and calories to drink whiskey. Now, your wife's an OD. Her name's Carol, right?
Yes, she's, at this point in her career, really become very, very part-time. She exclusively does low vision care. So it's great to have somebody at the practice doing low vision who's passionate about it. And she loves taking care of those patients.
Very rewarding. My career started out as a low vision specialist and evolved out of that. And your kids, what do they do?
So my kids, interestingly enough, are all in tech. So my two sons are in software engineering. So they're out with tech companies out in San Francisco in the Bay Area. My eldest son is with a pretty well-known company called Twilio. And my second son is with a startup, interestingly enough, in the pharmacy area. He's with a company that's doing virtual pharmacy called Alto. And then my daughter, who didn't go into computer engineering, she was really more of a marketing and PR person, actually got into technology through biotech. She's here, thankfully, in Chicago, and working with a company that's doing genetically based directive care for physicians in the area of cancer treatment, depression, and has been doing a lot of COVID work actually over the last year. So all my kids are one way or another in tech. And so when they get together and work remotely, they're sitting at a table with computers out, and I look at the screens and I don't understand what's on the screens because they're into code, So.
Yeah. Glad I was never into that. You need to talk to Walt Mayo, one of those ODs who knows code too. Well, listen, Barry, sounds like a beautiful family. Thank you for taking time out of your busy day to come on the show. I want to remind our members to go look at the International Keratoconus Academy website, keratoconusacademy.com. That's a mouthful to say 10 times fast. But sign up, get the education through the podcast, and Barry and the team of docs who are top-notch. All of them bring a ton of information that's free for you, supported by industry, and really helps drive benefit to the general public and your patients as well. So go there and do that. And Barry, this has been great. I hope sometime I can have you back on.
I would love it. This has been a lot of fun on a cold Chicago day. It's great to be on with you, buddy.
It's cold here too. I'm sitting in a drafty basement doing this. My hands are in my pockets.
Soon it will be better.
All right, my friend, listen, stay in touch, and I'll see you in the summer at a conference or somewhere optometry related, and take care.
Thank you, Alan.
Greetings, doctors of optometry. My name is Dr. Solomon Gould, and I am an optometrist out of the Twin Cities of Minnesota. I have 2 private practices and 2 stellar teams, and on this side, I love nothing more than helping other doctors be successful both clinically and, of course, as practice owners. I want to first especially thank my good friend, Dr. Alan Glazier, for the invitation to be a part of the great Fluorescene platform. I will be presenting on a variety of both clinical and practice management subject matters. And for today's first clip, I want to spoil you all with some great knowledge on private practice key performance indicators. Now, key performance indicators is simply a snapshot of how your particular practice performs in comparison to the national average. And I have information and data and metrics from what's called the Mean MBA database, which is essentially metrics and data from all private practices and actually corporate practices as well across the country. So as doctors of optometry, we generate our revenue from 2 key primary areas, from the chair and from the optical. The 2 key performance indicators I would like to share with you doctors today are, number 1, collections per exam. That's more generated from the chair. And of course, the capture rate, which is, of course, a metric in the optical. Now, of course, when it comes to key performance indicators, it's the apples to oranges phenomenon. No 2 practices are the same. But with this information, And with some trends I will show you, you'll be able to get at least a baseline idea as to where you are as a practice. And I'll share with you some clinical and practice management pearls to get you to your fullest potential. So starting off with the collections per exam. First and foremost, we don't have data yet for the year of 2020. So I will be sharing with you information and data from the years 2017, 2018, and 2019. Now, let's start with this collections per exam key performance indicator. So collections per exam is essentially what revenue are you generating per patient encounter. The trend and what we're seeing is that as doctors of optometry over the past 3 years, we have done a better job at this key performance indicator. We're generating more revenue, in other words, with each patient encounter. The metric collections per exam in the year 2017 was roughly around $359 on average. That jumped to, in 2018, around $366.80, and then in 2019 up to $370. Now, I also, in addition to sharing with you this trend, want to highlight something that's very important to know. First and foremost, as I mentioned, no two practices are the same. With that said, there is a disparity across the country between the performance of practices, and to no surprise, but in the upper 99th percentile of practices, this particular key performance indicator in the year 2017 was around $626. That jumped to around $658 in the year 2018, and then slight decrease down into 2019 at around $651. So they're generating that amount per exam, and that's the upper 99th percentile of practices. Comparing that to the 50th percentile of practices, where these metrics were in the year 2017, $348. That jumped to around $354 in 2018, and in 2019, that increased to around $356. So the trend was that it was also going upwards for the 50th percentile, but recall from that 99th percentile, the figures that I mentioned beforehand, the figures are actually double. So the upper 99th percentile of practices are performing double with this metric compared to the 50th percentile. So my big question to you, doctors, is why? Now, as a professional consultant, I know why. I know that what they're doing the right things at every step of the process. And of course, over the next several months, I will be helping you doctors how to navigate that and how to optimize your collections per exam key performance indicator. We're now on to the second key performance indicator, this one generated from the optical, and that is the capture rate. So we have seen national average here that capture rate key performance indicator has decreased. In 2017, 45% of practices were able to capture the patient coming out of the chair in the optical. That decreased to around 44% in the year 2019. It hovered in between there over the year of 2018. So we know that online sales are increasing, and that is affecting the capture rate in the brick and mortar modality. Just, a sheer figure here for you. Online eyeglass sales in 2018 were only roughly around 4.7%. But that has increased, and in 2019, that was up over 10%. So yes, that is affecting our capture rate in the brick and mortar setting. So now, once again, let's compare that upper 99th percentile of practices to the 50th percentile of practices. In the year 2017, the capture rate in the upper 99th percentile was at 88%. That then decreased down to 85% in the year 2018, and then 82% in the year 2019. Let's now compare that to the 50th percentile. Well, in the 50th percentile of practices, that figure remained consistently from 2017 to 2019 at around 43%. Remember, comparison here, that figure is also around half the amount, or half the capture rate, in other words, of that upper 99th percentile of practices. So what are they doing differently? What are they doing better in order to have that high of a capture rate? Again, over the next several months, I will teach you exactly how to do that. At my practices, I have roughly it hovers between 89 and 92% capture rate. And it is not me, it is a team effort that, again, I will bestow upon you great doctors of optometry. So I won't spoil you with too much information yet, but I will give you just a high-level clinical pearl and practice management pearl. When it comes to optimizing your chair-driven revenue, two big pieces of advice. Number one is to capitalize on the trends. And number two, consider a specialty practice or a holistic practice. Now, let's first talk about the whole capitalizing on the trends. There has been a significant shift in the consumer to a holistic or a preventative, prophylactic way of caring for themselves. So in the field of optometry, we're seeing great technologies such as CogniView, Pharmanex, Diopsis, AdaptX, MPod, NeuroLens, all these ways to really truly care for the patient more holistically. And as doctors of optometry, being a formative front-line primary care practitioner, we have the ability to incorporate this technology into our clinical repertoire. The second thing, as I mentioned, consideration of a holistic or a specialty practice. There's a lot of potential in combination with technology for dry eye, myopia management, specialty contact lens, or just overall holistic high-level care. Now, give you two little pearls for today's segment on the optical-driven revenue component. Number one, avoid common mistakes made. I see a lot of doctors of optometry, whether they're just freshly opening a practice or this is an existing practice and they're revising their optical, the two most common mistakes I see made are number one, more equals better. In other words, if I don't have every frame line, every lens option out there, I'm going to lose a customer. The second common mistake I see made is simply keeping up with the Joneses. If Dr. Alan Glazier has Maui Jim, I have to have Maui Jim. Now, what those two common mistakes will do or yield is what I like to call wallflowers. In other words, this is going to eat up your cash flow and it's simply going to collect dust. So my advice is to watch your key demographic, monitor your frame board management, see what burns and turns, and of course rely upon your reps for that, but have a finger on the pulse. Second piece of advice is to learn your generations. This is going to be a big segment of mine that I cannot wait to delve into. Learning your generations or working smart, not hard, is one of the most easy ways to be successful. And I mean that quite simply because a lot of times we burn ourselves out just simply trying to appease our customers and patients. And there are ways that you can be successful by simply knowing how to work with that personality type or that generation. That's it for me today, wonderful doctors of optometry. Again, a big thank you to my good friend, Dr. Alan Glazier, for the Fluorescene platform invitation. I cannot wait to come back with more on my segment. My particular passion, again, helping doctors be more successful in clinical care and practice management. And I can't wait to come back with you guys with my next segment here on FYEye with Dr. G.
Hello, and welcome to the Fluorescene Eye Care Industry News. This week in Neurology News, a prospective cross-sectional study published in the April 19th issue of JAMA Neurology determined that while incidentally detected signs of chronic intracranial hypertension on MRI are common, the signals are rarely associated with papilledema, as low as 2%. The researchers evaluated 296 outpatients who underwent MRI at Emory Healthcare and had ocular fundus images taken at the same time. Most, 63.5%, were women, and the median age for the cohort was 49.5 years. Patients with papilledema had a history of idiopathic intracranial hypertension and significantly greater body mass index, along with an increased prevalence of transverse venous sinus stenosis, empty sella, and optic nerve tortuosity found on an MRI compared with patients without papilledema. The occurrence of papilledema rose from 2.8% among patients with a minimum of one MRI sign of intracranial hypertension to 40% among patients with at least 4 MRI signs of intracranial hypertension. Investigators determined that further research is needed to determine which combination of MRI signs and clinical factors has the highest predictive value for papilledema. In glaucoma news, Glauconix, Biosciences, and Nicox SA co-authored a manuscript in Investigative Ophthalmology and Visual Sciences demonstrating the IOP lowering ability of NCX667, a novel nitric oxide donor. The article highlights the effectiveness of Glauconix 3D human tissue model in retaining biological and physiological features found in human trabecular meshwork and Schlemm's canal tissue. This model's relevance to the pathophysiology of glaucoma has validated and enabled confirmation of efficacy of development compounds that have now translated to commercialized products such as the ROCK inhibitors. This 3D human tissue model is particularly relevant to study compounds affecting physiology of the trabecular meshwork and its inner wall of the Schlemm's canal at the cellular level. In addition to the data on Glauconix's model, the article includes data on the robust and dose-dependent IOP decrease exhibited by NCX667 in various animal models including rabbit, dog, and monkey, thus translating across species. In Presbyopian news, a team from the Universitat Politecnica de Valencia, the Universitat de Valencia, and the AIKEN Ophthalmic Clinic have designed and assessed in their laboratories a new groundbreaking implant to correct presbyopia. As a result of the work of 5 years of research, they've created the first trifocal corneal inlay that is also fully transparent. This inlay, unlike others that currently exist, would not prevent subsequent study of the retina or macula, and even surgical interventions as the case may be. The inlay consists of a diffractive lens made of a biocompatible material less than 5 microns thick. The lens is microperforated, which allows the flow of necessary nutrients in this part of the cornea. In diabetes news, the Cleveland Clinic published a 1,041 patient retrospective analysis examining the effect of a delay in care on the visual acuity of patients requiring intravitreal injections. The authors looked at patients with retina disease who had received an intravitreal injection in the 12-week period prior to March 14, 2020, which was the start of the lockdowns. Patients in the study were divided into 3 groups: those that completed their scheduled visit during the time period from March 14th to May 4th, 2020, those that canceled their scheduled visit during that period, and no-shows. Upon returning to the office after those 7 weeks, patients who either canceled or were no-shows experienced statistically significant vision loss compared to the patients who completed their scheduled visits during the study period. The study's authors concluded that patients with DME and or proliferative diabetic retinopathy and retinal vein occlusion are most vulnerable to vision loss with even short lapses in care. A second study conducted by Dr. Ashkenazi and others from Bascom Palmer Eye Institute drew a similar conclusion. Alimera Sciences developed Illuvian, an implantable treatment for diabetic macular edema. The sustained-release intravitreal implant is injected into the back of the eye and lasts up to 3 years. It's designed to release a daily sub-microgram level of fluocinolone acetonide, a corticosteroid, for 36 months to reduce the recurrence of disease and the number of treatments required, enabling patients to maintain vision longer with fewer injections. In other diabetes news, a study published in Scientific Reports determined that diabetes affects corneal endothelial cells in patients that are older, as well as those who have suffered with the disease for at least 10 years and have a high glycated hemoglobin A1C. Patients with type 2 diabetes exhibited significantly lower endothelial cell density, higher variation in endothelial cell size, and greater central corneal thickness compared with a control group. Differences were larger for those with long-standing diabetes and A1C greater than or equal to 7. The study points to the need for patients with diabetes to undergo regular corneal endothelial examinations. In AMD news, Ashvattha Therapeutics announced the presentation of a virtual poster supporting the development of its proprietary HTT D4517 treatment for treatment of wet age-related macular degeneration at the 2021 ARVO Meeting. Hydroxyl dendrimers selectively target choroidal neovascular lesions after a single systemic dose. Hydroxyl dendrimers, or HDs, are taken up by macrophages, microglia, and hypertrophic retinal pigment epithelial cells and retain in these cells in CNV lesions for at least 1 month after a single systemic dose. Sunitinib has been shown to suppress neovascularization in animals and humans, but has significant off-target toxicity when administered systemically. Based on results from this preclinical study, a single subcutaneous or oral dose of D4517 resulted in comparable or better inhibition of CNV to a single IVT alfibricep dose at the same total mass. In more AMD news, researchers compared and reported 2-year treatment outcomes from 3 different anti-VEGF treatment regimens in treating age-related neovascular macular AMD. Ranibizumab PRN or ranibizumab treat and extend, and aflibercept fixed first-year dosing with treat and extend in subsequent year. They report VA improvement from all 3 different treatment regimens, with both aflibercept fixed and ranibizumab T&E regimens achieving the same higher final VA. Aflibercept fixed dosing may have more favorable efficacy with the highest VA gain and comparatively lower dosing frequency, whereas ranibizumab TE may be more effective than ranibizumab PRN regimen, according to our study. Whew, that word is a mouthful. And that's it for today's Fluorescene news. Enjoy the rest of the show.
Hi, I'm here today with Dr. Jackie Thies. Dr. Thies graduated summa cum laude and Phi Beta Kappa from Bucknell University in Lewisburg, Pennsylvania with her Bachelor of Science degree in Biochemistry and Cellular Biology. She then moved across the country and completed both her doctorate in optometry and residency training in neuro-optometry, binocular vision, specifically double vision strabismus, and vision rehabilitation at the UC Berkeley School of Optometry. After residency, she continued her research and became an assistant clinical professor at UC Berkeley School of Optometry, as well as the founder and chief of the UC Berkeley Sports Vision and Concussion Clinic. She's nationally recognized as a leader in her field for diagnosis and management of oculomotor dysfunction and concussion, as well as prismatic correction of acquired and developmental double vision. Currently, she works at the Concussion Care Center of Virginia in Richmond, Virginia. She's a fellow of the American Academy of Optometry and an active member of the American Optometric Association, California Optometric Association, and the Neuro-Optometric Rehabilitation Association. She's a national lecturer in neuro-optometry and sports vision and has a keen interest in understanding and improving visual performance and concussion. Dr. Thies was the California Optometric Association's recipient of the Young Optometrist of the Year Award in 2019. So welcome, Dr. Thies.
Thank you. You did great. Most of it.
There was a lot to get. You did a lot of, you've done a lot of stuff, a lot of writing, a lot of lecturing, unbelievable amount of interesting papers. And I'm really excited to have our first neuro-optometrist on the show, especially because, first of all, I'm excited to talk to you and I learned all about you, but also this week is
Brain Injury Awareness Week.
Brain Awareness
It's a month.
Week. Right. How about that? I did not plan that, by the way. I can't plan anything that well. Awesome. So welcome. And you're near me now. You're in Virginia, which is awesome area of the country, by the way. Richmond, there's so many things, or south of Richmond, right?
No, I'm in Richmond.
Oh, you're in Richmond. Awesome. Awesome town. What do you think of it?
I love it. I absolutely love it. And I've only known it in COVID quarantine time, so I really can't wait for it to turn back on.
Yeah, it's got a lot of character, a lot of history. You're close to the beach. You're 2 hours from DC and 4 hours from Philly. So there's so much to do. Beautiful mountains around there, hiking, biking. I love it. Awesome. Well, we're glad to have you here. I want to dig right into some questions I had for you. When I was going through the articles you had written, one was what concussion looks like. That was the title of the article. I never thought about a concussion having a look, but I'm intrigued. Can you elaborate on that?
Yeah. So the one nice thing, I have specialized in concussion and tried really hard to see mostly concussion patients or brain injury patients. And the joy of that is I don't see 1 or 2 a month. I'll see up to 100 a month. And when you start to see that many, you start to see patterns. And so there's definitely a pattern to brain injury and the ocular motor dysfunction that they have. They look very different than developmental. And the reason I think it's important to know how it looks different is because sometimes people aren't forthcoming about their concussion. That's where that article had come from, or that lecture, I believe. Because there's a couple of cases I've had where they're actually cases of domestic violence and child abuse. And I've had to ask the kid, have you ever had a concussion or been hit in the head? And they are very begrudgingly to tell you. I mean, an athlete will always be like, well, of course. But when it's domestic violence, they often will pretend that they don't, but they definitely look like they do. And so there have been a couple of cases that I've been able to catch by seeing what the concussion, seeing the ocular motor system and identifying that it's more likely a brain injury than a developmental problem.
Wow. So very specific, you're breaking it down into very specific categories of the concussed. Different types of patterns of injury lead to different patterns of ocular motor dysfunction.
Yeah.
And that's what that lecture or that paper is about. Interesting. Then that explains my next question, which was, what was the genesis of your title, Concussion in Kids, Different from Adults? And how do they differ, which I think you just answered. So that's great.
Yeah, well, and actually what's been interesting, so the concussion in kids was mainly how much it's going to impact their return to learn. I think people worry so much about return to play, and it's important because return to play is going to prevent people from getting re-injured. That's really the concern for return to play, is we just don't want you to get hit in the head again too soon. Because kids, there's never been a case that I'm aware of anyone over the age, I believe, of 23 that's had second impact syndrome. And so if you return a kid to play too soon and they get an injury, they can have severe dysautoregulation and die. These are the cases you always hear about, unfortunately, in the news. And they've never found that in adults. So definitely the brains react a little bit differently in kids than adults. And then the other issue that you have with kids is returning to learn. So I think what we've found is that the ocular motor problems linger much longer than all the other metrics they're using for returning to play. And so kids actually are returning to play too soon. And that's the big question we had when I was working at Berkeley was, when can someone return to play if they still have lingering cognitive and eye movement problems? Because those are always the last things to get better, which is, I think, a question I don't think the community's really answered.
Right.
But we definitely know it impacts learning if you can't read. So
there's such an emphasis of sports in our country that I would think, as a parent myself of two boys who played sports, that the parents would seriously take them returning to the field into consideration, but that's not always the case. What happens when you think that you may have a child that was abused, but how do you approach that? Because there's no outward scars or anything. Is it a touchy subject for you?
It's always going to be a touchy subject. I've had some females in domestic violence relationships as well, and those ones they're difficult to manage. The first thing I always ask them is if they feel safe. And the hard part with children is getting them away from a parent, to be honest. The couple of cases I've had with kids, actually, usually they're brought, in the couples I've had, the mother brought them and is the one that ultimately admits that, yes, their kid was hit. And then my next question is, what can I do for you? One of the things I always do is, I mean, we're mandated reporters, so there's something to being said for mandating abuse, but if the abuse is known, well, there's also things like contacting the pediatrician or the primary care physician, getting resources for patients. For instance, psych support is huge. I've recommended that any of my kids who've had domestic violence get psych support. I think we need to remember to refer for psych. And then it's just an uncomfortable topic to talk about with patients. And I feel sometimes they're not ready to hear it. And so the best thing that you can kind of say is, I'm here for you, and I want to do what you need, and do know that I can help you however you want me to help you. You can't, the frustrating ones have been, there are some where in female cases I've had, they don't want to leave. And there's nothing I can do about that except tell them that I'm here for them and I support them in any way that they need. I really appreciated when I worked at Kaiser. Kaiser has wonderful handouts to give patients. Kaiser does a really great job of training you in this. And so you could give them handouts if they wanted it, and just let them know that there are resources.
I love what you said about, it's a simple statement like, do you feel safe? Or if you ever don't feel safe, here's my number. Something like that is an open-ended way to approach it without judging or accusing anyone, just to kind of open that door a little bit and build comfort with the patient. So at the very least, you get more clinical information. At the most, maybe you'll help this person. I love that.
Yeah.
Moving away from those serious issues, let's go to one of your specialties within another specialty is, the focus of your work at Berkeley, which was on the impact of concussion on athletes. And particularly football has been a hot topic, of course, in the past 5 or so years. Tell us about some of the latest advancements that sports organizations have applied to kind of protect athletes from concussions. And is there any way to gauge whether it's reduced the risk or the severity of the CTE that is so, widely discussed now?
Yeah. So I think what we've learned so much about brain injury is that we don't know yet what we don't know, especially in relation to CTE. And I think one of the hard parts, having done research, is realizing just how complicated it is to be able to create a study that is solid revolving around brain injury, because every brain injury is different. And not only is every brain injury different, but even within one person, if they had multiple brain injuries, each one of those injuries are different. So it's really hard to compare them oftentimes. And there's a lot of great data out there, and they might not get published because they didn't, qualify concussion in one way or the other. The other hard part with the research in concussion is that there's really no true accepted diagnosis or definition of a diagnosis of concussion. It's a very wide umbrella. And so, especially if you do the comparative studies of this person had a history of concussion and this person did not, well, what definition are you using? Because back when I played sports when I was younger, if you weren't knocked out, you're fine. So you could go back in. And we're much more careful than we are now. I think the big thing that's really changed the landscape is we know that, I think don't know the exact statistic off of my head, but it's pretty high, like 80 or 90% of concussions, you're not going to lose consciousness for a mild brain injury. And I think that's a big shift, because it used to be, if they're with it, they can go back in. And now, especially in younger people, if you even suspect or you saw them hit their head, they cannot return to play until they've seen a physician and been cleared. And that's really important, at least for our research. I remember when we started doing a pilot study. So we had a bunch of questions that we were trying to answer, where I think one of the big questions was, all this ocular motor dysfunction, are we just unearthing things that were there before and no one knew about? Or is the concussion actually causing ocular motor dysfunction? That was a big question the athletics department had, because we didn't really know what to do with it at that point. And so we started baselining all of them in ocular motor dysfunction. And sure enough, we found about 30 to 40% of them had some sort of BV problem. And then when they would get a concussion, we would do the tests over again. So we'd see them in 24 hours and, 72 hours, 1 week, so on. And initially, when we were doing the pilot study, one of our physicians was doing near point of convergence, and I taught him how to do it so he could do it on the sideline. And then I would see them 24 hours later, and he would tell me, they look fine. And then I would see them, and their near point would be like 20. And I'd be like, can you just not do this test? Like, it's not a hard test.
Right.
And what we ended up learning is that sometimes a lot of the ocular motor dysfunction doesn't actually come until 24 to 72 hours after the injury. So even if you were to screen them on the sideline, you're not going to be able to pick up everyone. And so that's why it's so important that even if you don't think they have a concussion at the time, that you pull them and wait a good 24 to 72 hours to see if the inflammation in the brain comes around. Because that's what happens is on the sideline, they have all that adrenaline, they feel fine. And then the next morning they come in to see you and they just say, man, I feel like I got hit by a truck this morning. So, and that's hard to diagnose. I think sports physicians have the hardest job in the world in diagnosing concussion, because with adrenaline and with the game going on, most of the time they feel fine. So it's a really hard thing to diagnose on the sideline, especially when it doesn't evolve right away.
That's really important information for parents. My son, we wouldn't let him play football because of, all the concussion concerns and CTE, and he really wanted to play football. He wants to make football his career, not playing, but being behind the scenes. But we let him play lacrosse, and I've seen that where the next day something's off. That's a really important thing, I think, for parents to think about.
It's interesting how much people villainize football, by the way. I think football definitely has been in the media for it, and we can't say it's not. But from working in the athletics department, I think football gets a lot of concussions because there's a lot of people on the field. But if you were to look at other athletic sports that have less people, for instance, gymnastics, I think we had a gymnastics team of 10, and I would say 70% of them had a concussion at some point. But again, 7 compared to 50 on the football team doesn't sound like a lot. So football is going to be villainized. But any sport, really, you're at risk of getting a concussion. I mean, if gravity, everyone's at risk of getting a concussion. You can slip and fall at any point. Some sports are a little riskier than others, but a lot of the ones with the really bad injuries that people don't think about are like water polo or rugby. We get a lot in those types of sports where you're not wearing a helmet and you just get hit by another player.
Right. It's brutal. I played intramural rugby in college, and yeah, I was the little guy, so I was the hooker. Everybody's head just goes together into that scrum, and it's brutal. It's absolutely brutal. And you're
Yeah.
right. I don't know why we thought lacrosse would be any safer than football, but it just seemed that there would be less head-to-head, trauma, at least from my experience.
Absolutely. Absolutely. I mean, the big thing with football.
Sorry, go ahead.
Oh, I was just going to say the big thing with football is actually the subconcussive blows. So it's not actually the concussions themselves, it's the repeated hits to the head that aren't concussive. So essentially the O line and the A line going against each other.
Interesting.
Yeah.
Well, moving on, I read another article that was titled, I'm going to read this, Adaptation and Rehabilitation of Neurological Visual Field Defects. I think our viewers would be really interested in knowing that what are some of the neurological problems that respond particularly well to neuro-optometric rehabilitation, and what are some that don't?
So I think one of the big things about neurological visual field loss, so most of the time we're thinking post-stroke or post-surgical, they've got, a homonymous hemi. I think this is a low vision population that gets missed a lot because oftentimes they see 20/20. They see 20/20, but they're missing half their vision. And so oftentimes they just get told, you'll get used to it. And when they actually look at studies of patients, when you tell them you'll get used to it, only about 25% of patients are going to get used to their neurological field loss. And the other 75% just suffer with it. And if you proactively go in there and train them how to use their eyes to compensate for their visual field loss, they do much better. The other thing that people will do is say, oh, just scan to the left with your head. And that always, as a sports vision person, that always made me laugh because that's not how the brain works. We guide the entire body with our eyes. You never move your head somewhere first and then your eyes follow. It's always your eyes are guiding your body, your hands, your eyes. So when we teach people to scan, we need to teach them to scan with their eyes, not their head. And then show them how to do it in a way where they actually have to overscan to their blind side, which is super helpful. And then the other thing that we can do is prism.
Great. It sounds very much like what you are engaged in is more occupational therapy than vision therapy, or do they overlap? How do you differentiate yourself with what you do from vision therapy as we know it?
Sure. So, personally in my practice, I don't do any in-office vision therapy. So that's one thing. I like to call it, so neuro-optometric rehabilitation doesn't necessarily mean you're only doing vision therapy. Rehabilitation has to do with adaptation. So just giving people strategies to adapt to what they've lost. Compensation, which is the ability to compensate for something that you've lost using another system, and then actual rehabilitation of the system itself. And so sometimes post-stroke, for instance, you're never going to get that neurological field loss back. You can compensate for it, you can adapt to it, but if it's there after about 6 to 12 months, it's not going anywhere. So we have to figure out how to make you work around it and really empower you to live the life you want to lead. That's my big thing with all my patients is I want to figure out a creative way to get them to live the way they want to live. And that is a very OT mentality, absolutely, of worrying more about the person's activities of daily living and their function than necessarily the structure.
Sounds to me like it almost overlaps more with low vision than with VT.
So I'm actually on the AOA Vision Rehab Committee, and it's funny because all of us are a little bit different. Some of us do more neuro, some of us do just low vision, some of us do vision rehab, and it's neat to be on a committee where everyone's different, but we all treat patients. And a lot of low vision people will say, you end up seeing these patients and you either co-manage with someone who also does vision therapy or you do the therapy yourself.
That's great. So moving on again, I'm always drawn to the articles and lectures with interesting names. And one that really I zeroed in on when I read your work was Living in a Fishbowl, Iatrogenic Anisoconia, a novel treatment method. Can you tell us about that?
Yes. So this was a case that I saw during my residency, and I have a case series that I just have to write up. I haven't gotten to it yet. I've been busy. But essentially I had a patient who she came to me because she just had constant eye strain, and she had a very small esophoria, and she had some anisoconia, where one eye saw bigger than the other. And her history essentially was, before she went into cataract surgery, she was fine. And then she had cataract surgery and she just woke up with constant eye strain and it never went away. And we, through her history, found out that prior to cataract surgery, she actually had isoconic lenses because she was very anisometropic in her myopia. I think she was a -2 in one eye and a -7 in the other. So huge difference. And anytime you have a difference between the eyes greater than 3, usually it's a axial length difference in the eyeballs. It's not corneal or lenticular. And so the problem is when someone has an axial length difference, their whole life they've had image size difference, but their brain has been able to adapt to it. So what happened was when she was 70 and they took her cataracts out, they made her isometropic. So they made her plano in both eyes. And the problem with that is her brain still essentially magnifies the minified image from the axial myopia. And so the eye strain she was having was the two images battling together. And the problem is that normally with anisoconia, you can use isoconic lenses and kind of use contacts to make it better for this patient. But unfortunately for her, the cataract surgeon had accidentally made her more myopic eye, the more hyperopic eye. And so I couldn't put her in contacts and I couldn't put her in isoconic lenses. And so I was trying to figure out what I could do for her because I knew that at the end of the day, it was the anisoconia that was driving her crazy, because anisoconia essentially can cause binocular vision complaints. And so I found this study from like the 1970s in the Journal of Refractive Surgery. And this ophthalmologist had used this interesting system that I essentially adapted myself, where you create a telescope using a contact lens and glasses. So usually, right, when you're using contacts, there's always that downstream magnification effect of when you convert someone. So for instance, like a -4 in glasses, you're going to put them in a -375 for contacts. You're going to attribute that axial length. And what's so cool about this method is that in the eye that had the smaller image, what I did was I overpowered, so the P ocular, if you will, if you remember telescopes from school, I overpowered her contact lens over minusing it, and then I equivalently overplussed the glasses. And so essentially she's got a -1 contact and a +1 glasses. So she still sees plano, right? She's still seeing perfectly fine. She sees 20/20, but when she moves the glasses in and out, because it's only on one eye, she gets increases in magnification of like 3 to 4%, which was all she needed to make the images close enough in size for her brain to fuse them together. So it was kind of a creative way to get like 2 to 4% of image magnification versus the like 2.5x you get with telescopes. So
that's really creative. That's, you're turning the eye into a Galilean telescope.
Yeah, exactly.
Fantastic. Offline, I got to tell you a story similar to that you'll find compelling. So I want to move on to talk about diplopia. That's always an interesting topic. Those are probably the most interesting cases related to binocular vision that we see in our practices. Can you tell us about a particular compelling case that you treated, something that was like kind of out of the box and had a happy ending because of the treatments you applied?
Yeah, so I had actually just this week I saw him. I had a kid recently who was in a pretty severe motor vehicle accident, and it was so bad he had to get he had an orbital blowout, he had a nasal blowout. I think he blew out on one side of his face like every single orbital wall. It wasn't just like the inferior wall; it was the whole thing, and he had to get complete facial reconstruction. And unfortunately, he has a little bit of enophthalmos and restriction, and so he has really concomitant restrictive double vision. And so since his accident, they just patched that eye. And so he's super light sensitive. He has constant double vision and he's 18 years old. And that's not really a way to live. And so the first thing that I've found with a lot of my patients is patching makes light sensitivity worse. So we had to get him out of the patch. And so I thought, okay, well, we can just put, a Bang-It filter on some glasses for him so that we can at least get the light sensitivity go away, because that's super painful. But then I was able to see that actually in some parts of his vision, he can still see, we could actually get him to fuse with some prism. And so what I've started doing recently has been I know a lot of people for concomitant diplopia just say like, oh, there's nothing we can do. And I've been getting really creative with Fresnel. And so I'll put like a sector of Fresnel, maybe imagine you divide one lens into thirds. And let's say they're more ESO and right gaze. So then you give them 20 ESO in the right gaze portion, you give them 10 in the middle, and then you give them 5. So you actually can give them correction that's graded prism to give them fusion in all gazes. And so I was able to do that for him. And we've been slowly changing it as he's getting better, but it's just been so neat to see him, because getting him to see single and having him come back super excited, because he came back 4 weeks later. He goes, my light sensitivity's gone. I can see single. I don't care that these glasses are funny looking right now because I'm comfortable. And that for me is just huge, to be able to help patients like that.
That's incredible. You're custom crafting Fresnel.
Yeah.
Sitting there with scissors and angling it and positioning it. That's very, that's real doctoring. That's awesome. How did that make you feel with that kid?
It's great. It's one of the reasons that I love doing double vision. And I think anytime you tell people that you love diplopia, they look at you like you're off your rocker a little bit. And I think it's because I like helping people that no one else can help. I love being able to help those patients. And one of the reasons I transitioned to private practice is because these patients that I see are super complicated and they take a lot of time. And so I love having the ability to give them all the time that we need to fix it, which I think is sometimes harder when you're in a different setting.
Very rewarding. It's incredible. But going back to the anisoconia, have you used or do you apply the Shaw lens to any of those patients? Are you familiar with that?
I've never used the Shaw lens, and the main reason was because the places where I was didn't have access to it. Like I didn't have access to it, hence why I had to get really creative with what I had.
Absolutely. I find it works really well, and I've been using it for many years in specific cases, especially people who haven't been able to get relief anywhere, but no commercial interest in Shaw lens. I just think it's a great product for that specific.
I've heard great things from other people about it.
Yeah, it's a real lifesaver. Peter Shaw, who's an OD in Toronto, invented it, and he's an incredible guy. So check it out when you have a chance.
Yeah.
I have a question that's something I always wondered, that going back to sports again, you see such protection at least at the high school level, at least in our region, in our state, with male sports players. But I watched a female field hockey game, and field hockey scares me. I mean, those are hard balls, hard wooden sticks, and the female players aren't wearing helmets. They don't, and in lacrosse too in our area. What gives? Why is that? And how do you feel about that?
So yeah, passion topic for me is there is definitely inequality among the sports, and why people think women are gentle, I'll never understand. I remember I played soccer growing up and I got 9 concussions, and it's because I'm not gentle, right? And so I think there definitely needs to be some equality in how we're equipping and protecting our athletes, because it really doesn't matter what gender you are. When you're competitive in your sport, you're going to collide. And so we need to make sure that regardless of your gender, that you're protected for that collision.
Yeah, you're gonna get one of those hard wooden sticks in your head, or balls, or I just don't understand it. I was shocked, actually.
Yeah, and field hockey. Field hockey didn't exist when I was growing up in Colorado. So when I went to Bucknell, and there was a field hockey team, I was like, what is this game with like candy canes? And then I watched it and I was like, this is so intense. They are tough. So aggressive. Yeah.
It's tough. There's way too much opportunity for serious injuries in that sport to see them playing it without helmets. That's just something that really bothers me. Well, it's good to get your take on that. Now, we're going to wrap it up soon, but let's talk a little bit about you. I read and learned that you're into a lot of outdoor activities. Being from Colorado, I guess that has a lot to do with that. Snowboarding, surfing, trail running, yoga. And one of my favorite activities, hiking with my dog. What kind of dog do you have?
I now have 2. So I have a Dachshund Spaniel, so he looks like a permanent golden retriever puppy. And then I just adopted a new one a few months ago, and he is a Shepherd Beagle mix. So
interesting. Save
kind of an interesting. They're both rescues, yeah.
That's awesome.
So the newest rescue is really giving me a run for my money.
That's fantastic. We have a golden doodle. He's awesome. And then now that you're in the area, we said we would definitely connect and get together. And when we do, we're going to go out for Korean food, because that's one of my favorites. And I think that's one of yours. At least that's what you put in your email there.
It's absolutely one of my favorites. It was the one thing that when I was moving to Richmond, I was like, what does it not have? And everyone's like, just so you know, it doesn't have good Korean food. And coming from San Francisco, where they have incredible Korean food, I was like, I'm just going to have to take that trip up to DC.
Yeah, that must have really hit you hard. You'll have to learn how to cook it or make some Korean friends.
Yeah.
It was Korean food.
Well, it was actually my Korean friends here that told me that there was no good Korean food here and that I had to go to DC.
Guess what? I'm coming up for dinner, bud. That's awesome. Well, listen, this has been really fascinating for me. I learned a lot, and I got my questions answered about the female field hockey helmets. So that puts that to rest. Although it doesn't put it to rest, we really have to protect everyone, regardless of their sex. And if it would be okay with you, could I get you to commit to coming back sometime and talking about some other stuff?
Sure. Yeah.
Awesome. Anything else you want to talk about or add today, or we basically covered a lot of interesting things?
I feel like we kind of ping-ponged around a lot, so I feel like we covered a lot.
Well, there's so much to talk about in the field. So I want to thank you for being here. This is, like I said, it was fascinating, and we will have you back in the future. And anybody who wants to get in touch with you, what's the best way for them to get in touch with you?
My website, www.virginianeuro-optometry.com. All my contact information is on there, so you can find an email and email me through there.
Awesome, Jackie. Well, again, thanks for coming on, and we'll talk again real soon, okay?
Sounds good.
Awesome.
Hey everyone, thanks for joining us here today on the Fluorescene Show. On tonight's episode of Who's Got Glaucoma, I will be discussing an interesting case of optic atrophy. This is a case of a 25-year-old African-American male that was referred by their retina doctor to our clinic for a glaucoma evaluation. The patient was originally referred to the retina specialist by their primary eye care physician to rule out any retinal pathology that could explain why his VAs were not correctable to 20/20 in each eye. The retina doctor has said his retinas were unremarkable and had recommended a glaucoma consultation. This patient denied any history of ocular injury and denied any history of ocular surgery. He reported that he was in great general health. He denied any medical conditions at all and stated that he was not taking any medications. He denied any family history of glaucoma. The patient's entering visual acuity was 20/40 OD and 20/30 OS. Pinhole did not improve VA in either eye. The VAs were taken with his entering spec RX as shown here. His IOPs were measured to be 16 OD and 17 OS with Goldman tonometry. Gonioscopy revealed deep angles OU. Each quadrant was open to ciliary body OU. Pachymetry revealed a thin cornea OD. It was about 500 microns. And a slightly thin cornea OS. It was about 530 microns. The anterior segment exam in the slit lamp was completely unremarkable OU. Now I'm going to show you his disc photos as I go over my fundus evaluation. On the optic nerves here, I graded the cupping at about 0.6 in each eye, and I noticed significant temporal atrophy OD greater than OS, as you can see on these pictures here. I did note that his superior and inferior rims were pink and healthy OU. Here are his OCT, so you can see the significant temporal atrophy OD greater than OS. And here is his visual field. On the right eye, you can see a central defect here, and on the left eye, a shallow central defect and some nasal depression that's non-specific. In glaucoma, although central defects can occur, it's not common. It's not as common as the arcuate defects and nasal steps that we tend to see. At this point, I diagnose this patient as a glaucoma suspect OU and advise him that I would be monitoring him closely, but that no treatment was indicated at this time. I had also referred him to a neuro-ophthalmologist for an evaluation because he's a young, healthy patient with VAs that are not correctable to 20/20 and presents with temporal atrophy, the optic nerves, OD greater than OS. The neuro-ophthalmologist did the evaluation and agreed that it was most likely a congenital or hereditary optic atrophy as opposed to normal tension glaucoma. He had ordered some testing, including MRI of the brain and orbit, and also some blood work to look for common causes of optic neuropathy. All those testing came back normal. However, the neuro-ophthalmologist still felt like it was presumed hereditary optic atrophy as opposed to glaucoma, and had been following him every 5 to 6 months. I myself have been following this patient at our clinic for the past 1.5 years, and at his subsequent 4 to 5 visits, his exams have been stable. His IOPs had remained in the normal range, around mid-teens OU at each visit, and his disc evaluation had remained stable at each visit, with the cupping staying at 0.6, and the visual field here, you can see the second visual field in the right eye is about the same as the baseline with that central defect. The left eye visual field, there is a bit more of a central defect compared to the baseline, but again, this is not the classic glaucomatous patterns that we usually see. On the OCT here, you can see that the second OCT is stable to the baseline OU. So this is an interesting case because visual field defects do not always equal glaucoma. This is a young, healthy patient. He's only 25 years old, presents with normal tensive IOPs and moderate cupping, but healthy superior and inferior rims, which are the most important aspects of the nerve for glaucoma. And he doesn't really have many risk factors for glaucoma. He doesn't have any family history of glaucoma, and his corneas are slightly thin, but that's really his only risk factor there. He doesn't have sleep apnea, history of headaches or migraines, or anemia. None of those normal tension glaucoma risk factors there. This is also an interesting case because it demonstrates co-management with other specialties. So in complex cases like this, don't be afraid to send the patient out for an evaluation in another specialty and co-manage with them. And in cases where it's not very clear cut, that's glaucoma and the pressure's normal without really any risk factors for normal tension glaucoma, it's definitely okay to monitor the patient closely and track for disc progression or glaucomatous visual field progression. I hope that this was helpful. Thank you again for joining us today. We'll see you on the next Fluorescene show.